Good evening. Thanks for coming out. I don't know if you have post-election euphoria or post-election hangover, whichever may be, but we appreciate you coming out tonight. We're not going to talk politics directly tonight. We're going to talk healthcare, and in particular, health information exchanges and the issues surrounding both patient issues regarding medical records, electronic records. Medical providers have these issues, how state and federal policy gets involved. To do that, we have our colleague Niam Yaraghi out from Brookings Institution this week. This is Niam's first visit with us as a visiting scholar. So he's been meeting with our faculty and students and people in the community to get a sense of this issue in Nevada. And we're going to hear his perspective on it, and we'll have time for some Q&A at the end. So I want to thank my colleagues at the Greenspun College of Urban Affairs who co-sponsor our lecture series with us. And I'll turn the podium over to Niam.
Thank you very much, Bill. And thank you very much for being here. This was my first visit to Las Vegas, and I had a blast out of it. Not from the Strip, because honestly, I didn't find it really attractive. Whatever was on the Strip, I had already seen in the movies. What was really interesting for me about Vegas was to know more about the economy and the politics and how the people are coping with these issues here in Nevada. Is a completely different story, something that you may not expect to hear. So I really enjoyed my visit here, and I appreciate you being here. Since it's a small audience here, I was thinking to myself that I may change the style that we are presenting this. So please feel free to interrupt me whenever you wish. If there is any question that you want me to talk about it, please feel free. And do not limit yourself to the topic, which is health information exchange. And I understand that you do not have a fully functioning, developed health information exchange platform in Nevada. So if there is other issues related to the general topic of health IT, please do not hesitate to ask. I will try to respond if I can, and if I cannot, then since it's a small audience, I would be very candid and I say I don't know. So my dissertation was on health information exchange, and by the way, I'm a fresh graduate, as they say, right out of the college. And what I was studying in my PhD was about adoption, usage, and patient privacy in these systems. But before I go into the presentation, let me tell you how I'm going to talk about it. First of all, I'm going to give you a brief introduction on the main concepts that I build my research on. And then I am going to present 3 papers published in 3 journals: ACM Transactions on MIS, Journal of American Medical Informatics Association, and the last one, which is forthcoming, in Information Systems Research. And then I try to talk a little bit about my ongoing research, and after that we would have a Q&A. But again, don't stop asking any kind of question that you want during the presentation. So what is a health information exchange? Health information exchange is a system that connects different kinds of healthcare providers together so that they can exchange the medical information of their patients together in a timely manner and in an efficient manner. So you may have different medical providers, such as primary care specialists, labs, radiology centers, or even insurance companies that come together, build a platform in which they can retrieve the data, store the data, and then share the medical data of their patients with each other. And why are these health information exchanges are such a big deal? Because they really make an impact. 20% of the total expenditure in the United States healthcare system can be attributed to waste. It's either waste due to malpractice and errors in the medical procedures, or it's due to errors of the administrative process of the healthcare system. So health information exchange systems are promised to significantly reduce the costs of the healthcare by a couple of ways. The first one is that they can reduce the redundancies in the healthcare. So suppose that you go to Los Angeles, California, and you have to take a blood test. You do it, and then you return back to Nevada, and you want to have a follow-up visit with your primary care. If those two doctors are a member of a fully functioning health information exchange system, then your primary care doctor here in Nevada does not need to reorder an additional lab test. He just can log into the system and view the previous lab test that you took 2 days ago and then make a better decision based on that. The second process through which the HIEs, or health information exchange systems, can reduce the costs is by providing a complete picture of the medical history of the patients so that the doctors can make better decisions. And by making better decisions, they can reduce the cost of the healthcare and also provide higher quality healthcare services and help the patients. However, despite all of these benefits, which there are some estimates as much as $70 billion a year, health information exchange systems still have so many different challenges and problems. The first one is that the adoption of health information exchange is way below what the Department of Health and Human Services had anticipated. And the reasons for that lack of popularity are different. There are interoperability, governance, financing, policy, and privacy issues, as well as financial incentives and workflow problems. Just to give you two examples, one of the main concerns that doctors, and especially doctors in the emergency departments, have about HIE in general and electronic medical records in particular is that they are a pain in the neck. They believe that these systems come and intervene with the usual way that they provide care to the patient. So now, instead of paying attention to the patient, they feel obligated to just enter so many different types of medical data into these systems, and then reading 400 pages of data that most of it may not be relevant. So there is a workflow problem that is a burden in using the HIE systems. And the other one, which is I believe a more important one, is the financial incentives. Basically, due to the current payment structure that we have in the healthcare system, there is no significant financial incentive for a particular doctor to put an effort in using these systems. So although we tend to consider physicians as saints who have no incentive other than providing the best care for their patients, the financial incentives play a very important role. And physicians are very highly skilled professionals, and if they have to spend 10 more minutes in using these systems, in providing a better care to you, then what would they get in return for that 10 extra minutes that they spend in taking care of a patient? There is no solid financial incentive for the physicians and the people who are using it, mainly because there is no solid measurement of the actual benefit of using these systems. So it's like gambling in Vegas. Sometimes you win, sometimes you lose. You win if you get a very important piece of information out of the systems and help the patient. And there are so many times that either the patient is not in a critical condition, so that going back to the HIE systems and getting their records is not as that much important, or there is not much information about that. So the doctors don't know that actual use of HIE would definitely make an impact. So it's like a treatment plan that is very uncertain. So due to these problems, health information exchanges have not been that much successful. The federal government has poured so much money into these systems. It was a part of the stimulus pact to pour in as much money as they could in order to incentivize physicians and hospitals to adopt electronic medical records and actively engage in the exchange of health information. However, although we see a very sharp increase in the rate of adoption of electronic medical records, there is not much effect of those incentives in the actual usage. So I was asking myself that how we can find other mechanisms that can incentivize the physicians to use the systems other than giving them dollars. So I modeled health information exchange systems as a multisided platform. And what is a multisided platform? It's a system that has two sides or two or more sides, just like a credit card. You as a buyer is one side of the platform, and then the seller that you go buy stuff from it is the other part of the platform. So health information exchange systems can also be viewed from that perspective. You have primary cares at one side, emergency departments and hospitals at the other side, insurance companies at the other side, and specialists at the other side, and the patients at the other side. So there is a unique feature about multi-sided platforms like credit cards and health information exchange, and it's called network externality. So imagine that you are making a decision about buying a laptop. So when you want to buy that, you take in so many different factors. It's price, it's functionality, and everything. But you really don't care if other people are also using that specific brand of laptop or not. However, if you want to join Facebook, then you would care how many of your friends are already on Facebook, because the value of the Facebook depends on how many other users you are going to interact with on Facebook. So no matter how cool Facebook is, no matter how secure it is, no matter its price, which is free, and it really doesn't matter unless you have enough friends that are already on Facebook and it creates enough incentive for you to join Facebook. The other classic example of network externality in multi-sided platforms is the cell phones. So if you do not have enough friends who are also using the cell phone, then having the cell phone and being the only one in the world who has a cell phone, although it looks cool that you're the only person who has a cell phone, is not going to have any benefit for you because you cannot call anybody. But if you have more and more of your friends having cell phone, then the value of cell phone increases, and that is exactly the reason why these providers are offering free talks if you call another person on the same network. So AT&T says that calls from AT&T numbers to other AT&T numbers are free. Well, now everything is free, but up until a couple of years ago, If you wanted to call somebody else on the same network, it was free. But if you wanted to call somebody from Verizon and you had AT&T, then you were going to be charged. They had these pricing structures in order to use this network externality and incentivize you to go on a plan that your other friends are already on. So there are a couple of people who you usually talk, all of them are on AT&T, then definitely you are also going to be on AT&T. So there are two subgroups of network externalities. One of them is called within group or direct externality. The other one is called between group. The within group externality is the benefit that you get from the other users on the same side, and between group externality is the benefit that you get from the users on the other side. In a minute, I will talk more about this. So there is a classic model in the marketing called Bass diffusion model, which basically talks about how a new product or innovation diffuses in the market. And Bass has two groups of people. The people who are innovators and go and buy or adopt a new product or innovation as soon as it becomes available. So those guys who sleep in front of the Apple stores before an iPhone becomes available are the classic examples of innovators. These guys are more affected by the outside sources like marketing and mass media, while the other group are called imitators, and these are the people who wait and look out and wait and look at the other people's experiences with a specific product, and these people are affected by word of mouth. So you wait until your friend gets the latest iPhone, and you wait and see if it bends or not. If it didn't bend, then probably you would go and buy it. So this is how Bass shows this model. It says, suppose that this big circle is the potential market that you have, and there are a very small group of Apple people. I don't want to use the word Apple zombies, but Apple big fans who are really into Apple and gonna start buying it as soon as something becomes available. And over time, as soon as this group of early innovators hit a critical mass, the word of mouth starts to diffuse in the market, and the imitators start to buy. And as they buy and talk more about a product, more and more people buy until the market is saturated. So there is no more customers for the new product. And this is the mathematical representation of that. So Bass tells us that the total number of the people who adopt a particular product at time t is a function of the market size and two coefficients. One of them is P, which he calls innovation coefficient, and the other one is Q, which he calls imitation coefficient. However, there are two shortcomings in the Bass model. The first one is that he does not consider the heterogeneity in the market. So he says, let's assume everybody are like each other, which clearly they are not. And second, the other limitation of the Bass model is that it does not consider network externality. So it's a perfect model if you want to model the sales of a washing machine. It's a perfect model if you want to model the sales of a laptop. But as soon as you want to model the sales of a new phone plan, then it would not be able to do that. So my first paper is on network effects in health information exchange growth. It's already published in ACM Transactions on MIS. And what I do here is I develop a diffusion model that can basically bridge the gaps or the limitation of the Bass model. It considers the market, it considers that healthcare market is a heterogeneous market. All the doctors are not the same. The people are different from each other. And the other one is that I can also incorporate the network externalities in my model. So this is, let me just show it on a picture. Instead of having one group, here I have two groups. I call them primary care physicians and specialists. And not only you have within group effect, which is the same effect as word of mouth. The people was talking about the new iPhone to their friends and everybody. So the diffusion of health information exchange is happening within the primary care people as a function of the adoption of other primary care people. So if I'm a primary care doctor, I adopt this system, I talk with my other primary care doctor friends, and they also adopt. However, there is also another effect here, which I call it between group effect, and that is the effect of adoption by a primary care doctor on a specialist, and also the effect of adoption by a specialist on a primary care doctor. So there are two groups. So I consider that the doctors are different. We have primary care doctors and specialists. It's a very simplified model, I know, but still, it's still better than BAS model. And then not only we have word of mouth, but also we have imitation from group A on group B and vice versa. And this would be the mathematical representation for that. I had originally planned my presentation to be for 1 hour, but since I'm going to go over all these mathematics, I think we can stay here until 10. So what I have here, instead of having only one group of adopters, I have two groups of adopters. I show them with Y1T and Y2T. Y1T is showing the number of the primary care doctors who have adopted the system until time T, and Y2T is the number of specialists. Everything is basically the same. The major differences that I have here is that the adoption among the primary care doctors is not only a function of Q1 and P1, which were the coefficients of innovation and imitation within the same group, but also I have Q21, which is the coefficient of imitation from specialists. So a primary care doctor not only cares about advertisement, not only cares about how many other primary care doctors have already adopted, but also cares about how many other specialists have adopted. The same story is true for the specialists. They not only care about the media, they not only care about other specialists, but also they care about the primary care doctor. The question is, which of these forces is more powerful? So the data that I use for my research is real data. Is coming from Healthy Link, which is an organization, which is a regional health information organization in charge of promoting health information exchange in Western New York. And they were kind enough to provide, to bless me with a really great data set. So this is how the data looks. And this part of the data is publicly available. If you go to their website, you can see the exact same thing. They tell me the practice name, the physician, the specialty of the physician, the date that they have joined the system, and some additional information. So based on this information, I can just group the physicians into two groups, the specialists and primary care doctors. Primary cares are family medicine, internal medicine, physician assistants, nurses, and specialists are everybody other than that. By the way, primary care also includes OBGYN. So estimating that big analytical model based on the real adoption data gives us some cool estimation. So now let me tell you what these numbers are talking about. First of all, it shows that the primary care physician and specialists are affected by media differently. So you cannot say that running an ad in the local newspaper or putting an ad on the billboard is going to have the same effect on the primary care doctors and specialists. The second thing is that the direct network effects within each group is different from the other group. So one of the things that we know about the innovation in the medical field is that the doctors don't care about media. They don't care about, you know, these advertisements, or they don't even care about the detailers from pharmaceutical companies. They care about their colleagues. They wait and see what the other person is telling them, what are the experiences that they had with a new drug or a new medical procedure, and if it was successful, then they're going to adopt it. In the HIE context, not only is it true, but also we're showing that primary care doctors put a different value on the input of other primary care doctors than the specialists put the same value on the input of the other specialist doctors. And there are two more interesting things about that, and that is there is a network effect between these two groups. So primary carers care about specialists, and also specialists care about primary care doctors, and this effect is much more powerful than the within group doctor. So if you have a typical specialist and you want to persuade him to adopt the HIE, then you would better show him some examples of other primary care doctors who have joined the system. The other cool thing about these estimations is that primary care doctors create the most significant and most powerful effect here. So the example that I tend to give is like nightclubs. If you provide free admission to ladies, then it's going to create a much more powerful effect in attracting gentlemen to the club. If you provide free admission to men, then you're not going to attract any women to the club. So primary care doctors are just like that. If you want to have if you want to attract specialists, you'd better go get some primary care doctors on board. And in a minute, I would explain the medical reason behind that. So there are a couple of policy implications. First of all, was that the primary care doctors are the most important one. The second thing is that there are other forces in the market rather than mere distribution of dollars among doctors and telling them that we will give you $60,000 or $70,000 if you go and comply with the stage 2 meaningful use and adopt HIE and all those things. So even if you are going to design some financial incentives for the doctors, then you would better consider these differences and these market and these drivers in the healthcare market into your design. So if you have a limited amount of budget and you want to get the best return on your investment, the best strategy is to give more money to primary care doctors and less money to specialists, because if you give more incentives to primary care doctors, you would have more of them on board, and as soon as they come on board, then the specialists would follow. But what is the medical justification behind this observation? That comes from the actual flow of patients. Usually the patients start their journey in the medical system from the office visits at the primary care doctors. Those are the ones who are the first step in the medical process. Those are the ones who create the initial reports, and those are the ones who refer the patients to specialists. So if the only people on the system are specialists, then they are not going to exchange that much patients between each other. So they're not going to get anything out of the system. But if there is a specialist and there are so many other primary care doctors already on board, then he would say the likelihood of me receiving a patient from one of these primary care doctors is so high, And if they are already on the system, then there is also a very high likelihood that there is enough medical information about that particular patient on the system, so I will get some benefit from this. But if there's only specialists on the system, then it would say, what percentage of my patients are those who are referred by the other specialists? It would probably be a lower than the ones that he is receiving from the primary care doctor. So they would put a higher value on the primary care doctors than the others. So that was the first one. The second paper also talks about these externalities and flow of patients. However, I do a different kind of market segmentations. In the first one, I was only talking about primary care and specialists. In the other one, I talk about professional proximity and the geographical proximity. The data that I use here is not only the adoption data, the first one that you saw, but also is the actual HIE system logs. So based on these data set, I can know which two doctors had viewed the medical records of the same patient. So if Dr. A and Dr. B had viewed the records of patient X, then that would be identified in my data set. And based on this data, I calculate the ratio of the common patients between each pair of the specialties in my data set. And the ones that have the highest ratio of common patients would be grouped together. So I would come up with some clustering like this. That here I have three groups, the blue ones, the black ones, and then the green ones. Two black ones may be an allergist and a dermatologist, because it's very likely that the patient goes to a dermatologist and says there's something on my skin, and then the dermatologist says that you should go to an allergist to get more information about that. So those two specialties are probably having a lot of common patients between each other, the set of patients that visit both of these specialties, versus an allergist and a dentist may have very little number of shared patients between them. They have nothing to do with each other. So following the same argument about the flow of patients and the value that the flow of patients creates, you would expect these specialties that are grouped together to be affected by the adoption of each other much more than the adoption of the others in the other groups. So an allergist would care about the adoption of a dermatologist and would not care about the adoption of a dentist. So if you extend that large mathematical model into three groups, so now you have group 1, group 2, and group 3. Each of these groups are the specialists that are shown with a different color. And if you want the complete list of the specialists in these clustering, you can go to the actual paper and get the list. You can extend the model so that you can say the physicians in first group not only care about the other physicians in the same group, but also they care about the physicians in the second group and the third group. However, they care more about themselves than the others because they receive more patients from the other physicians in the same group than they receive patients from the physicians in the other group. In other words, allergists receive more patients from dermatologists. They receive less patients from dentists. So what these numbers are telling us is basically confirming what we already had. So Q12 here is the imitation or emulation effect. And the reason that I use emulation here and not imitation is because I had a primary care doctor as one of my co-authors in this paper, and he didn't like the word imitation to be used for doctors. He wanted to use emulation, and I didn't want to argue with him, so I said emulation. But it's the same thing, imitation. So imitation effect from group 1 on group 2 is shown by Q12, and its coefficient is 0.04. But now look at the emulation effect within group 1. So basically, the doctors within the same group, it's 0.12, basically is 3 times more than the effect of group 2 on group 1. So they care about themselves. The same trend repeats in the other pairs of the groups. So the flow of the shared patients among the specialists within each cluster creates significant network externality, and the clusters which do not considerably share patients between each other do not create network externality. The implications and the policy implication of this is that the design of effective HIE promotion policies, the flow of patients between different medical providers, should be taken into account. These two papers together are basically talking about the fact that you should consider the differences between the physicians, you should consider the flow of the patients between them, and you should consider the potential utility that each of these physicians get from HIE, and then based on that, go and decide about different incentive mechanisms that you would like to have in the market. It's not like you're going to give the same amount of money to different doctors without considering the fact that HIE has a different value for them, and they have different effects on each other. The other clustering mechanisms that we had was based on their geographical locations. So these guys in the black dots are the ones who are located in the urban areas of Western New York. The ones around them, the blue ones, are the ones located in the rural areas of New York. So I was interested to see if there is any effect between rural and urban. In a nutshell, again, the same effect is happening here, but the effect of adoption of HIE by the doctors in the urban areas is much higher on the doctors in the rural areas. So it's like fashion that moves from the main cities and major cities to the more remote areas and rural cities. This is the first one. The second one is that the doctors who are inside populated urban areas really care less about their other counterparts in the same area because they have higher and better access to the alternative channels of receiving medical data. They're closer to the labs, they're closer to the radiology centers, and they're closer to the main hospitals. So if a patient comes to them, if they do not have HIE, then they just say, go downstairs, get another lab test, and come upstairs, maybe tomorrow, 2 days from now. But the same doctor in a very remote area cannot say that, because the patient has to travel 100 miles to the closest lab and then come back. That is the second one. And the third one is that the rural physicians are highly affected by the word of mouth of the other rural physicians. Just in contrary to the urban physicians. So urban physicians really do not care what the other urban physicians are saying. I don't know why, but the doctors in the rural areas depend on each other's opinion much more than the physicians in the urban areas. So these two papers together, the policy implications that they have is get the primary care physicians in the urban areas on board. So primary care physicians, because the first paper was showing that they have a higher impact. In the urban areas is because the second paper is showing that generally the doctors who are in the urban areas are the ones who lead the fashion and the others would follow them. The second one is that approach the specialists who share more patients with primary care doctors, which is basically acknowledging the effect of patient flow and that the utility of HIE for the specialists would be higher if they're already sharing a lot of patients with the other primary care doctors. And as soon as you do that, you would have basically different cluster seeds that would grow on themselves. So you have a bunch of primary care doctors who are sharing a lot of patients with some other specialists, maybe in more remote and rural areas. And as soon as you identify them and you incentivize them to adopt HIE, then there is a good chance that these clusters are going to slowly grow so that you would have a universal system. I had another paper to talk about, but I think I'm already close to my time limit. So I will just give a very quick overview of this paper, and then we will open for Q&A. So this paper is again talking about adoption and also usage. So I'm not only interested in the adoption of HIE, but also usage. The difference here is that it's a more granular view of the HIE systems. So I use social networks theory, and also I study the Big Brother effect. What is the Big Brother effect? Is that one of the big guys, one of the big hospitals adopt the system. What happens on the other smaller, individually owned practices and physicians? So I create two networks, basically. The first one is called the network of patients. This is how it really looks like, based on my data. Each of these dots represent a medical practice. And each of these links between these dots represent a patient. So, and the size of each dot is basically based on the number of the patients that they share with the others. So if there is a very large dot, it means that there is a practice who is sharing a lot of patients with so many other practices, versus when there is a small dot, it means it's a practice that only shares patients with a small number of other practices. So you see this guy here, it's a very small, because it is only sharing patients with maybe one of these large practices. And the ones in the center are much larger because they are the ones who are sharing with so many other practices. They're probably the major hospitals that different physicians send patients to them. And then you create another network in which, again, the nodes are the practices. However, the links are the physicians. And those are the physicians who practice in multiple practices. They have their own privately owned offices, and they have admission privileges in multiple hospitals. So the practices who share a lot of common physicians with the others are the large ones here, and the smaller ones are the ones who really don't share with any other practice. And basically here, what I wanted to do is to see whether the location of a practice within the network of common patients and within the network of common physicians is going to affect its level of HIE use or not. And when we estimate it, it does. So there are a couple of different things. First of all is that the value of different HIE services for each practice is unique. So I define the HIE services by the type of the medical records that you can get from the HIE. It can be a radiology test, it can be hospital transcriptions, or it can be lab reports. Each of these type of services have a unique and different value for each type of practice. So one of them may be more interested in lab reports, the other one may be more interested in the radiology reports. The other one is that the practices learn how to use HIE through experience and shared physicians. So as time goes by and practices gain more experience with HIE, their level of HIE use increases, which is trivial. But the other interesting point is that the practices who share a lot of physicians with the other practices who have already joined the system have a much higher usage level than the others. And again, it's coming from the fact that the doctors really do not like to sit in a class. They like to, they say we don't have time, but I think it's more like an ego problem. They like to learn from their their counterparts. So if you have a practice that is sharing a lot of physicians with other HIE members, and they see how HIE is working and learn about the benefits, they come back and talk about it, and then the practice is going to adopt the HIE and use it at a higher level. The other cool thing that we find here is that the nurses are an important driver of HIE use. They are the actual end users of HIE. To be frank, the doctors are not going to go log into a system, search for your name, get your reports, and probably print them. They ask their nurses to do it. And if a practice has a higher ratio of nurse to physician, then it's going to use HIE more. Not only because they have the labor for that, but also because nurses generally tend to have a more positive attitude towards HIE. It's the tool that makes their life easier. The doctors don't care, you know. It's the nurse's problem. And this tool is helping the nurses and makes their life easier. So there are some research that shows that the nurses are going to have a positive impact on the physicians, and they're going to go tell them, you know, my other friends in the other hospital are using HIE. It's much easier to work with HIE. Please go adopt HIE. So they have a persuasive power on the physicians to do that. And then again, competition affects HIE. The practices who are more competitive use HIE at a higher level. And again, the same phenomenon that I was observing in the other two papers are also shown here, which says that referred patients increase the HIE level, increase the level of HIE use. So if you're receiving more patients from the other practices, then you're probably going to use it more. This is let me finish here. I had much more things, but my email address is here. I would love to hear about you if in case we didn't have time to talk enough about these issues, then feel free to send me an email. And just to give you a very quick overview of what I'm doing now, I should mention that right now that in Western New York, the company that I'm working with is very fortunate because it's one of the rare HIE platforms that have grown significantly and has a significant user base. Now they are interested to see what are the financial impacts of their services in the emergency department settings. So briefly, what we are observing is that the use of HIE in the emergency departments, if it's at 100% level, which means that you use HIE for every single patient that walks into the emergency department, no matter how critical his condition is, then you would save something about $150 to $200 per patient. And this is based on the assumption that a lab test on average costs $100 and a radiology test costs on average $500, which is lowballing. So imagine the savings in an emergency department for a year if for every single patient on average you're saving $150. And again, thank you very much for listening to me. I know sometimes I talk too much. I hope that I have not put all of you in sleep. I noticed that I have put some of you in sleep. But please feel free if you have any questions to ask. Thank you.
Well, I would just like to comment, as a nurse of 30-some years.
Okay.
Nurses don't love medical records.
Yeah.
We know that it's necessary to decrease waste and mistakes.
Mm-hmm.
We get that. And we are the ultimate end user, and we are still hand-holding the physician through the whole process.
Correct.
To get them to adopt this, I can see that the incentive is not financial, obviously, because it's been a slow adoption process, even with the stimulus money.
Yeah.
It's still very, very slow.
Correct.
And I really do appreciate how they're going to try to look at how to encourage the adoption process. But how long of a process is this going to be? I mean, how long do you see it being?
Well, you know, the adoption is one question, and then the actual usage is another question. If you're talking about adoption at the minimum level, and that the minimum level, I am referring to the standards that the Office of National Coordinator for Health IT has put for the qualifications to receive this incentives. Since they put the bar so low, then we are already there. So there is about 97% among hospitals and something about 85% among individual physicians about the mere adoption of the system. But the problem is that they adopt and they don't go near it. So if you're asking about adoption, I would say we're already there. If you're asking about usage, I would say only God knows. And the problem there is, as I said at the beginning, is first of all, the workflow. Even for the nurses, you don't love it, although it's going to help, it's designed to help nurses and physicians. It's still very far from that stage because it's not user-friendly and your current workflow is not designed to accept this thing. So as long as that problem is not solved, I don't see any improvement in usage of it. The second problem is that there is no incentive for either nurses or physicians to use it. So, you know, a primary care doctor says that if I use the HIE system and or if I hire a staff member from my office to go and get this information for every patient, and then when a patient gets discharged from the hospital, comes to my office, I use the HIE to prevent a readmission to the hospital, then I'm saving a lot of money for the hospital because the Medicare and most of the private insurances are not going to pay for the readmission of the patients for the same medical complaint to the hospital. So hospital would be the biggest winner here. However, what would be the benefit to the primary care doctor other than, you know, the fact that it provided good care, good service to the patient, he or she may feel really good inside, you know, that he did the best that he could for a patient, but to be honest, where is the dollars? There's no financial incentive for the primary care doctor to use the HIE system. And to be honest with you, they prefer to just reorder duplicate tests. They don't care, they don't pay for it, and they don't want to waste their time go look for something that has no benefit for them. So the workflow problem is a big one, as you mentioned. The other one is the incentives problem. How are you going to really incentivize physicians? How are you going to share the cost savings with the people who actually help to save those costs? So as long as these two problems are not adequately addressed, I really don't think that we are going to have a significant HIE use. Yes, please.
Oh, actually, I'm going to ask about your assumptions. First, well, as an example, I'll start with labs, and even though my specialty is not labs, you first talk about, like, there's an incentive for rural physicians on laboratory services. Right now, the system exists that everybody gets reports electronically. Physical transportation becomes irrelevant. You transport blood. So whether you're urban or rural is irrelevant in terms of interaction with the lab. What I'm going to ask, did you actually investigate HL7-4 and HL7-5 in terms of formatting? Because you're implying that when I get a lab report, it's readable under all different national systems have different formattings, and sometimes reports are unreadable depending on which format method you have. How did you address that?
This is an excellent question. And I didn't address it because the organization that I was working with had no problem with that. And this is how they solved it. So there are a small number of major data providers, such as labs and radiologies that you were mentioning, in that geographical region. All of them are already on board. So there is no problem with the interoperability of sending the data to the HIE database. No matter what lab it is, they can upload all the data to a central database of health filling. And health filling keeps these records. Then there are different users who are primary care doctors and specialists who want to use these systems. And there are three situations. They have a really cool EMR system that can receive this data and read this data. So they wouldn't have the readability problem there. But there are other two situations that the other group of physicians are the ones who cannot read this data. So they don't have a good EMR system that can receive this data from the HIE database into their electronic medical record system. And the third group are the ones who even do not have an EMR system at all. So there's no way for them to receive this information through an EMR system. The way that they resolve this problem is by creating a web portal called Virtual Health Records, in which every physician is provided a username and password, something like an email. They log into that, and then they just can search manually for a particular patient, and then view all the records on the web. So they have partially solved the problem of not being able to get the data through this virtual health record system that they have.
Well, and again, it goes back to, let's look at Utah as the model, where in fact the key was financial transactions, because when a lab orders several, or when several tests on the same patient ordered by different physicians, not within an ACO, an accountable care organization, you don't know that that lab is for the same patient unless you have billing transactions. Now, there was a fellow who was governor of Utah named Mark Levitt, who was also HHS secretary. So Utah went to a demonstration model where all billings are done through a portal so you can track transactions. So how are you making the assumption, unless it's within an accountable care organization, that two different labs can be tracked to the same patient? I mean, you're making the assumption that it can. And I guess I'm asking, how are you making that assumption?
So just let me show you how the raw data looks, and maybe that would help. So this is the actual SAS output of the data that I have, okay?
But you're using Western New York, right?
Yes.
But that's an exception because they created an HIE with interoperability. That's not true of the rest of the country. That's why I'm asking those questions, because you're assuming that is the standard around the country.
No, I'm not assuming that. I'm just saying that in the organization that I was using that, it was not the problem, so that I didn't want to answer a problem that does not exist, at least in the organization that I was working with. So I would love to be able to see how these models would be different if I was working in Nevada, which maybe the interoperability is a big issue, or I really don't know if you have a functioning HIE here or not. So I have not looked at it because, first of all, I was not interested in it, although it's a very important national problem, but the organization was supporting me and giving me data did not have this problem. So when there was no problem, I didn't know how to solve it. There's no question there. And the second thing is that I didn't have enough or no data that could help me approach that problem. So the honest answer to your question is that if you're asking me what would you do if you had the interoperability problem, and how could you track the patients, and how could you match the different lab reports that are created by the same lab ordered by different doctors to the same patients, the honest answer is I don't know, because I don't know. I have never seen the data about that. I have never thought about the strategies that I could match.
Oh, so you're looking at only within or intra HIE networks, not inter HIE networks. The interoperability question is a Tower of Babel in the country.
Yeah.
And it's a Tower of Babel for physicians, and yet, I mean, you choose. I mean, like Santa Barbara had that for a while.
Yeah,
Western New York
it failed.
You pick models where you started with the solution before you even got to the question. I mean, rather than picking models of heterogeneous markets.
I think, this is a dilemma that we have all as researchers. The data is a problem, and then the questions is a problem. I would have loved to be able to answer the interoperability question, and I would probably have answered that if I was studying in Utah, for example. If I was doing my PhD in Utah, then the organization that I was working with, the first question that they had is that, hey, how are we going to approach this interoperability problem? Then my PhD dissertation would have been totally different, focused on interoperability. And I wish it was the case, because I had more interesting things to talk about as interoperability as a national problem. But at that point of time, that was out of question. So I just wanted to get the data that I have and answer the most questions that I can with this. Yes, please.
Well, I think, with affordable care in general, again, from an outside person with a technical background, but just kind of outside of the actual healthcare world, I think I would have to concur that even with ACA and a lot of the aspects there with their software health exchanges, it just wasn't, and especially if they let it go state by state, rather than just having a big federal exchange, there's just going to be a lot of interaction and software work that still needs to go on. I mean, I think I'm seeing that really around the country, even in a broader sense.
Something as simple as LabCorp versus Quest. Which standard you go to will affect hundreds of millions of dollars to one corporation versus the other. There is no neutral answer unless you force both to go to a new system. And we're talking about publicly held companies with massive impacts on their stocks based upon which standard. This is the problem you run into with the Tower of Babel that everybody faces, other than very discrete interoperability within HIEs, which really tend to overlap with accountable care organizations.
Well, letting things go state by state, like I'm a retired federal employee, at least we had the overall federal program, with it going state by state too, it's just...
So there are two comments
the interaction
that I would like to make. The first one is that, I don't know if you're familiar with the Jason group or not, but it's quite a fascinating group. It's a secret group of the brightest people in the country, including so many Nobel laureates. And nobody knows them, and the federal government keeps them secret because the federal government asking them to answer questions that are so important that it does not want those fellows to be affected by the outside source, powers. Okay, so they keep them secret, so nobody knows if that fellow is a Jason member, so they're not going to approach them and trying to affect the way that they think about the problems. And these guys usually advise the government on issues such as, nuclear problems with Cuba, or what to do with the Cold War and all such things. So this is the level of this group. For the first time ever, 1 month ago, Jason released its first report on interoperability in healthcare in the United States. And it's the one and only report that Jason has created in an issue such as healthcare. All the other things is about nuclear things, how to deal with, uranians and all those stuff. So it basically shows how important this issue is. And I encourage you to read the Jason report. It is trying to answer so many of the questions that you asked. However, although the head of the ONC called the Jason report as a gift to the nation, I encourage you to read that and see if they are able to answer your questions. The recommendations that they come up with is a general software architecture based on using APIs and patches in order to enable different systems to talk to each other. However, it's much harder than that. That was the first one. So to be honest, I really don't know. And if Jason doesn't know, I don't feel bad that I don't know. So that is the first one. The second thing is about your comment about having a state-by-state approach. I think that is already the approach. So what they are proposing is that you're going to promote HIE within geographical regions, which is easier to work with, and then connect these geographical regions within a state to have a statewide HIE. And finally, down the road, they're hoping to be able to connect all of these HIEs in all of these states together so that you're going to have a nationwide health information exchange. So that is the dream. Are they able to reach that dream? I would say they should be, because although it's a very major problem, to many people it sounds so ridiculous that in this day and age, with this technical capabilities that we have, we're not able to address the issue of interoperability. So just one last comment that I want to make. It's really funny. You know? It's political. Exactly. That was the one I want to say. It's political problem and it's an economic problem. There is no reason that I want to share my patient's record with you. So
No, it's not that. It's standards.
And standard. So if you consider different vendors in the market, like Epic, for example, is having a huge market share. How are you going to talk with Epic in order to, provide some capabilities in its software to make it easier to be connected to their systems?
Or if you were trying to do that JSON program with all those tiers and levels,
Yeah.
how many trillions of dollars would that, or billions, anyway? Trillions. Yeah.
For the convenience of our visitors, I always like to try and finish our time, but we'll stay and take some questions if you want to stay and talk. If you haven't had a chance to ask your question yet. I just wanted to thank Niam for introducing a very important topic, and to all of you for your questions and pointing out both how important and how difficult the road ahead is. And it's something that we in Nevada are going to have to face and may or may not be dealing with as well as we should. So this discussion is to be continued.
Yes.
And thanks again for coming tonight.
Thank you again. Thanks.
We'll be back in a couple of weeks with it will be our final lecture of the semester. If you may remember Carol Graham, if you've been coming to lectures before, Carol will be back talking about her global work on looking at world protests and opportunity for people, what spurs protests, using social data to be able to actually predict in that endeavor. So Carol's, if you haven't heard her, I really invite you to come. She's both a great speaker, and it's on a very important and dynamic topic. So that'll be in 2 weeks, not next week. But thanks again, and please, if you have some more questions, we'll be around.